Good afternoon, everyone. Greetings from NITRD and a heartfelt welcome to all our esteemed guests and colleagues gathered here today for the launch of Paediatric TB Eco Clinic in collaboration with the Regional Paediatric Center of Excellence for Tuberculosis. On behalf of NITRD, I extend my warm greetings to our DDG Sir, Dr. R.P. Joshi, and his team, directors and team from NIIT, NTI, STOs, directors of STDCs, faculty of medical colleges, district TB officers, medical officers, and TB pediatricians, and everyone who is present to attend today's session. The Pediatric TB Eco Clinic aims to disseminate the pediatric TB guidelines and enhance the capacity of health providers in managing pediatric TB at the peripheral level. The Department of Pediatrics at NITRD is continuously contributing to the global cause of TB elimination by providing excellent care through treatment, training, research, policy decisions for pediatric tuberculosis control in the country. The department being the National Center of Excellence for Pediatric TB and for the treatment of DRTB care under the NTEP program by the Ministry of Health and Family Welfare under the leadership of Dr. Sangeeta Sharma. Let me introduce the faculty from NITRD. I am Dr. Saroj Meena, Senior Chess Specialist, and will be moderating today's session. To my right is Dr. Sangeeta Sharma, ma'am. She is currently directing the institute, and to the extreme right is Dr. Vishwadev Shah. He is our third-year resident. To my left is Dr. Yalok Yadav, sir. He is CMO NFSG at NITR. Now I request our director, ma'am, Dr. Sangeeta Sharma, ma'am, to give her inaugural address.
Welcome each one of you to this. I'm really honored to host this inaugural session of Paediatric TB Eco Clinic, which is an initiative and it stands as a testament to the dedicated efforts and the collaborative spirit of the national as well as the regional centers of excellence, guided by the Central TB Division. Now, the aim is to strengthen the pediatric TB care by involving and spreading the knowledge to our DTOs, STOs, our pediatrician colleagues, and faculty as well as residents from medical colleges. We have been successfully running the adult TB Eco Clinic as well as e-NITI, which is for the nurses, for last many years. So this was my vision to start this as an initiative, and we have today gathered over here with the collaborative efforts of each one of you who have joined us in this inaugural session. So without wasting further time, I'll now request my colleague, Dr. Saroj Meena, to carry this session forward.
Thank you, ma'am. So now I request our DDG sir, Dr. R.P. Joshi, sir, to give the inaugural address. Sir, please.
Thank you, madam. Namaste. Good afternoon, all. This is very heartening to note that NITRD is taking the lead again in launching this pediatric TB Eco Clinic. They have been running the difficult to treat clinic successfully, which is itself a real achievement. And pediatric TB is something which is very important for us as doctors, because pediatric TB presents in different ways. It is very difficult to detect, suspect, and even confirm. Getting a sample with like sputum sample in adult is taken for granted. But for pediatric, even getting a sample is difficult, and many times it doesn't present with the typical symptoms or signs. So I really congratulate the team at NITRD, Pediatric Department, Dr. Saroj Meena, Dr. Alok Yadav, and all the others, and the director led by Director Dr. Sangeeta Sharma. And special thanks to each one of you for participating. See, for any initiative of this kind, it is the active participation which motivates the team to do better and better. So your feedback, your participation is very, very important. I request each one of you to spread the message among your colleagues and friends. Let them take the benefit of this And I also look forward to hearing from you about the feedback, what exactly you people expect in the future episodes, what is the topic, what should be the any other improvements we can make. I'm very sure the team will be happy to look at it, consider it. So with that, I thank the Dr. Mattu and team in CTD who were instrumental in bringing out pediatric guidelines in associated other experts. And again, welcome you all, and I wish the initiative a grand success. Thank you all.
Thank you so much, sir. Your words always encourages us to do better and better in future. So with these kind words of our DDG, sir, we would like to officially launch the Paediatric TV Eco Clinic. Now I request Mr. Babu Ramachandran, he's a Senior General Manager from Eco India, to give his address.
Good afternoon to everyone. Namaste. And it's again another important day for all of us from Eco India. And special thanks to Madam Sangeeta, who has taken initiative when we talked about when the country is in need of pediatric related guidance periodically. And I always see this as a voiceless population. It's quite challenging also when it comes to diagnosis and management TB among children, especially infants and children. And most of the time, we may not be able to appropriately provide an adequate care. So this has been our long pending initiative, and of course, with the guidance of CTD, Joshi sir and plus Martu sir, Sabiko Satme, we have just started this, and in fact, we started working with some of the regional center of excellence also in the past. Now we see this as an opportunity, and our association with NITD has been more than 8 years, and always Delhi shows the way. Of course, when it comes to NITD, shows the way for TB. Be it early days of Delhi started with the 25 chest clinics, and later it got expanded to today. More than 32 states are conducting independent TB clinics, and more than 100 hubs are helping different TB institutions across the country. And that front, again, we feel it's an honor and opportunity to support the National Tuberculosis Elimination Program on behalf of the Eco India team, and under the guidance of CTD and NITD. And my humble request, all the center of excellence, regional center of excellence, to coordinate. And as we all know, we wanted to see this impact down at the peripheral level to ensure that each infant or child who is in need of TB care can be provided with the improved TB care services with engagement of various physicians who are involved in diagnosis and management of TB. So on behalf of entire Eco India, we thank you for the opportunity. We wish to support the National Tuberculosis Program in multiple ways. And once again, special thanks to entire team. And again, we are so blessed to have DDG staff. And again, I'm seeing parallelly Ashok ji also, who is always there with Eco India to support various activities. And I request you, sir, to disseminate this information to all the medical colleges in coming days. Of course, I think upcoming zonal task force meetings also, again, I see as an opportunity to disseminate, so that an equity can be ensured when it comes to the TB care, be it a child, be it an adult, or any age population that way. And ECO would be happy to support the requirements in this trend. Thank you once again. All the best.
Thank you so much, Mr. Ramachandran. And with the Eco India support, we are able to disseminate our knowledge to even to the peripheral part of the country also, and it is helping us to manage difficult cases even from this platform. So with this, I request everyone, there is a pre-test link has been shared on your registered email ID. Please attempt that before we begin the session with the case presentation. So moving on to today's case presentation. Today's case is from the Department of Pediatrics, NITRD. And Dr. Alok Yadav and Dr. Vishwadeep Saha have worked up on the case. Dr. Vishwadeep Saha will be presenting today's case, and Dr. Alok Yadav, who is CMO NFSG, will also serve as a case expert for today's case. The national expert for the day will be Dr. Sangeeta Sharma ma'am. She's also directing NITRD.
So just a brief up, for our participants. I would just like to say that we having this clinic on every third Tuesday, 2 to 3 p.m. And being the first session, we have started with a very simple case, and then as was decided in our preliminary online meetings with our other colleagues, the national TB experts. So we'll be building up on the level of difficulty. I mean, so we are, it's a stepwise approach. Today's case will be a very simple case, and we'll be building up with the further sessions as we move along this ladder. So over to Biswadeep.
Good afternoon, everyone. Firstly, I would say I'm really fortunate to have got this opportunity from my river director, ma'am, Dr. Sangeeta Sharma, and my work in pediatrics. And I'm very fortunate to set up my first case as pediatric TB eco clinic. So I'm Dr. Vishwadeep. I'm a third-year resident of NITRD, and my today's case is a 6-year-old female child with chief complaints of cough since 1 month, low-grade fever since 3 months. She also had history of poor weight gain since the last 10 months, generalized weakness, and poor oral length. Her informant was her mother. So the child was apparently doing well 3 months back when she developed low-grade fever associated with generalized weakness and decreased oral length. She also had cough, which was present since 1 month, which was usually non-productive and was not associated with any kind of postural duodenal or seasonal radiation. She was not gaining weight for the past 10 months, and she did not have any other history of hemoptysis or chest pain. As per the birth history is concerned, she was given birth by normal vaginal delivery at home. She cried immediately, and since she was delivered at home, the birth weight could not be measured. She attended all developmental milestones, which is appropriate for her age. As per the immunization history is concerned, her mother could not give a proper and it was not available. There was no past history of TB for this child, and there was no prior history of hospitalization or any other illness in the past. Among the history of contact, the child did have her father who died of pulmonary tuberculosis 2 years back, and the treatment records were not available. Her elder sister was also diagnosed with TB 4 months back, and she is on treatment for drug-sensitive TB since January 2024. So as we can see, this is the chest X-ray of the child, which is taken in a PA view with adequate exposure, with no significant rotation, taken in a mid-inspiratory plane, which shows that the child has right upper fibrocapillary lesion and bilateral fluffy infiltrates, which are present mostly in the left mid zone, the left lower zone. So based on this, we admitted and we examined the child. General examination showed no significant finding except for pallor. Also, the anthropometric measurements showed that the child had a very severe weight, very low weight at the time of admission, only at 10.5 kgs. It was again -3 standard deviation. Height was 102 centimeter, and she had a BMI of 11.5 kg per meter square, which is again below -3 standard deviation. She was severely underweight. The systemic examination was insignificant except for the respiratory system. We showed bronchial breath sound in the right mammary area, coarse crackles in the right infraaxillary and the infrascapular areas. So as we can see, this is the NTP format of CBNAT and of the CBNAT report. We took a G aspirate of this child. The smear was negative, but the G aspirate for CBNAT showed MTB was detected. It was low, and grip resistance was not detected in the report. So based on this, we started this child on the drug-sensitive TB regimen on 27th of April 2024. Almost 2 weeks after that, on 8th of May 2024, the child again presented to NITRD with complaints of pain abdomen, nausea, and vomiting for the last 3 days. It seemed that the symptoms aggravated after ATT intake. So in view of persistent vomiting, decreased oral intake, and poor general condition, she was admitted. ATT was withheld with a possibility that it might be a drug-induced liver injury or an ATT-induced gastritis. So we investigated and we sent all the blood investigation for this child, which was significant for the fact that the child was anemic. Her hemoglobin was 8, and as far as LFT is concerned, we can see that the LFT is deranged. The child had hypoalbuminemia as well as the total bilirubin. SGPT, SGOT, all other liver enzymes were almost 4 to 5 times raised from the normal limits. So we also investigated further and we sent for the viral markers. The viral markers came to be negative, all the three for hepatitis A, hepatitis B, as well as for hepatitis C. The child was also seronegative for HIV. We did an ultrasound whole abdomen for this child, which showed the child had multiple peripancreatic, mesenteric, as well as periumbilical lymphadenopathy. The largest measuring with a short axis diameter of 1.6 into 1.7 centimeter. No organomegaly was noted as far as USG is concerned. So, in view of severe disease, as we can see, as we have seen in the chest X-ray, the child was started on a modified regimen of streptomycin, levoflox, and ethambutol as per her weight. And a repeat LFT was done after 3 days. So we can see with this trend of repeat LFT that when the child presented to the hospital, the first day the LFT was deranged, SGPT was almost 5 times and SGOT was almost 4 to 5 times raised. The child also had symptoms. But after the stoppage of ATT, as the subsequent reports are concerned, the SGOT as well as the SGPT are slowly reduced. And so we introduced the following ATT, the following anti-tubercular drugs in this particular sequence of rifampicin, followed by isoniazid, followed by pyrazinamide. With the subsequent introduction of the drugs, we saw that the child tolerated, the child also did get symptomatically better, and finally the LFT was normal and the child was again restarted on the drug-sensitive TB regimen. So the final diagnosis for my patient would be she is a case of rib-sensitive PTB with abdominal couch along with drug-induced liver injury with malnutrition. Thank you so much.
Thank you so much, Dr. Vishwadeep, for the excellent presentation. I can see Dr. Sanjay Mattu has taken out his time and to join our this session. Welcome, Dr. Sanjay, sir. Dr. Sanjay Mattu is a Joint Commissioner under the Ministry of Health and Family Welfare. So may I request to give you, kindly give your inaugural address for 2 minutes of inaugural address, please.
Thank you, Dr. Sangeeta Madam and NIT RD team. So this difficult to treat TB clinic has been a very good initiative. Earlier we were having this difficult to treat TB clinics for DRTB cases, and with the initiative and the novel idea from the director, Madam Dr. Sangeeta Sharma, this difficult to treat pediatric TB cases is also very novel idea and much needed concept which we need to pursue, because as DRTB is very difficult to treat on the similar grounds, many times pediatric TB cases also fall in that category. And in field level, many practitioners and the service providers face this problem, how to treat the pediatric TB cases. It may be because of the diagnostic challenges, and many times it may be the treatment challenges. Sometimes the drug adjustment, or when the DRTB in pediatric age group is there, then also it is a very challenging area. So I think with this initiative, we are going to learn many new things when the difficult cases from across the India will be discussed on this platform. So new skill development will be there, not only among the pediatricians, but among the general practitioners also, which are providing services through the CHCs, district hospitals, and through PHCs. So my best wishes are there. Only one request is this, that CTD team was not shared this information about this, and VC link was also not shared. So CTD may be informed well in time, so that we can prepare our team also to participate in this, and we can plan, because if this information would have been with me, I could have planned it better. I am having another meeting of with one of the Unite for TB, and it is scheduled in the same timing. So that was the things were happening. The same timing, 2 meetings had happened. So I was not able to join earlier because of these 2 reasons. That one meeting was already coexisting with this timeline, and then other was the VC link was also not with me. So these were the 2 things. My best wishes are there, and we hope these learnings will be adopted in the programmatic settings and will give some better results. one more observation from my side is that we don't know that I think the presenter or the experts may explain this ESO regimen which was there. This we had levofloxacin, streptomycin, and ethambutol also, because nowadays streptomycin we are not using except in some meningitis cases. So this case belongs to the current period, or it was earlier period, or it fall in the salvage regimen. So those things may be explained during the discussion. Thank you all, and all the best.
Thank you so much, sir. And we are really sorry that the link couldn't be shared with you on time. And we are thankful to you still that you are able to make it out your this time from your busy schedule. And regarding the ESO regimen, yes, we will be discussing it in detail as we proceed with the case. So just to summarize the case, as many of us have joined little later. So this is a case in discussion is a 6-year-old female child. She was presented to us in the month of April with the complaints of fever, loss of appetite, and poor weight gain for the past 10 months. And she was with this complaint, she was being investigated and diagnosed as a case of PTB on the basis of CBNet report, which was if sensitive. PTB was being diagnosed, and it was started on drug-sensitive TB treatment. And after stabilization, the patient was being discharged from the ward and sent back home in a stable condition. But after 10 days, the patient reported again to the OPD with complaints of persistent vomiting, nausea, and pain abdomen. Because the patient was in dehydration, general condition was very poor. So patient was admitted under pediatric wards, and the patient was further investigated. It was found out that the patient developed drug-induced hepatitis, for which the drugs were withheld for initially. And then because of the severe disease, the patient was having cox abdomen plus PTB, which was bilaterally involved. We started the patient on a salvageable regimen, that is modified ATT SC-LEVO. That was the reason behind it, and we'll further discuss it in later. Patient was being managed conservatively, and gradually we introduced the ATT once the LFTs were stabilized. And after almost 10 to 12 days of hard work and patience, we were able to reintroduce all the ATT to the patient and able to discharge the patient in a stable condition. Any questions regarding on history from the house is open? The house is open for all kind of questions. Please. So there are a few questions in the chat box. Let me take one by one. Sir, Dr. Aru, will you take that question? So, Dr. Khushbu, she's asking that shouldn't be INS should not be stopped in this case of delay. Is that to be followed, as there was some update in 2023 guidelines that INS should not be stopped in this case?
Basically, in the salvage treatment, we do that because the liver enzymes are increased in this case. So this case is of drug-induced liver toxicity. So in the case of the liver toxicity, INH is also a drug that causes liver toxicity. So we stop the drugs which causes liver toxicity, just like a INH and rifampicin and pyrazinamide. Then we add the drug generally ethambutol, streptomycin, and levofloxacin. We add in this case streptomycin is added because the child has very severe form of the TB, and bilateral chest X-rays are involved and abdominal TB. And so we add streptomycin.
Thank you, sir. So there's another question which says that yeah, as the father was expired from TB, but we failed to get any documentations from the relatives of the patient. Is that true, Dr. Vishwadeep?
Yes.
Father's detail?
Yes, the father actually died of tuberculosis 2 years back, but when we asked history from the mother, actually no documentation was present. We did not know what was the status. Whether the father died of a RIF-resistant PTB or not, we did not know that. So yes, the history was not available. So again, we have to evaluate this child more intrinsically and more like properly to see that she might have developed any apart from RIF sensitivity, she might have developed any other kind of like resistant pattern on.
So there's one more question. So does at the time of presentation the child had edema, pedal edema, or what was the regimen at which the patient was discharged?
at the time of the admission, the patient did not have any severity. And when the child was diagnosed as a recurrent sensitive pulmonary tuberculosis, we start the drug sensitive regimen. As per the weight band of the child, the weight band of the child is 10 kg, so we started to C plus 2 and drug sensitivity.
The only thing I would like to add over here is in the first question, because as Dr. Mattu has also said that streptomycin now, under the program we can easily replace with amikacin. And the advantage of amikacin is that it can further be given IV. So, it saves the child of intramuscular injections. Any other questions?
Ma'am, can amikacin, clindamycin, ethambutol can be taken as an acceptable regimen? considering all-
Clindamycin? No. Clindamycin, no. No.
And it
I
was,
mean, streptomycin can be replaced with amikacin SE levo. I mean, in this case, because it was a case of, bilateral pulmonary tuberculosis, which falls under severe pulmonary TB. For our pediatrics, severe and non-severe, we need to understand. Non-severe is where there is less than one lobe involvement and it is smear negative. There is uncomplicated pleural effusion. If there is a mediastinal lymphadenopathy, it's not causing any compression. So this is non-severe case of pulmonary TB, and extrapulmonary TB non-severe is only one thing, that is peripheral lymph node disease. If you have non-severe disease, then you can even keep a wait and watch, not start anything. But in this case, because it was bilateral disease, that is bilateral extensive pulmonary tuberculosis along with abdominal lymphadenopathy. So we had to start a salvage regimen. And the salvage regimen which we have been giving is SE levo. Streptomycin can easily be replaced with amikacin. And we add each drug one by one. Once the LFT they touch the normal, that is, they become less than 2 times the normal. So that is the time of introduction. I think Dr. Alok, you can explain well. I mean, how to go about once the LFT, they become the serum transaminases, they become less than twice the normal, and the bilirubin reaches less than 1, and the child has no symptoms. That is the time, you introduce one drug at a time. I think you can take that up.
yes, ma'am, we'll be asking Dr. Alok's expert opinion after finishing these questions. So, ma'am, can there will be low albumin levels can be risk factor for developing delay?
I mean, obviously, when you have low albumin level, that clearly highlights that the child is having a comorbidity. That is malnutrition, and malnutrition and tuberculosis, they go hand in glove. I mean, TB causes malnutrition. Malnutrition is a cause of worsening of disease. So we have to take care of both, and it's a well-recognized comorbidity, malnutrition, diabetes, HIV, which in children have to be dealt with, specifically. So we have to maintain a proper diet chart, and as the child appetite improves, because right now when the LFT is normal, the child won't be accepting things orally. So once the LFT starts to improve, that is the time to introduce the nutritional rehabilitation part.
Thank you so much, ma'am. Dr. Vishwa, what were other clinical features of nutritional deficiency in this patient?
Yes, ma'am. So, as far as the general examination is concerned, the child was actually cachectic. She had pallor, and as far as the anthropometric measurements are concerned, so the weight was also below -3 standard deviation. She was only 10.5 kgs. As far as age is concerned, she should not be so less in weight. Her BMI was also very less. That's 11.5, which is again -3 standard deviation. So she was severely underweight. So, these are actually the risk factors which disposes a child, especially at this age, to because there is a There we can clearly see there is a deficiency in nutrition. The albumin was less. The child was not gaining weight for the past. So these are some of the examination findings which we saw in this child, which led to the diagnosis of drug sensitivity.
So let me call Dr. Alok Yadav because he was a case expert and was patient throughout her stay in the hospital. Sir, can you please give your expert opinion on this case and the challenges you have faced in diagnosing and managing the patient?
Thank you, Dr. Saru. Basically, we have taken a field case which we are generally seeing in our OPD and indoor cases. As the pediatric tuberculosis, as we know, the diagnosis and to manage and the drugs which we are giving is different from the adult cases. So our motto is to how to approach the pediatric TB in those groups who are generally working at the district level and who are not pediatricians working, but working in the program. So basically, this patient which is presented in our OPD is actually have cough, fever, not gaining weight, decreased appetite, and also contact with the parent. The father died due to tuberculosis 2 years back. Basically. So first, the child is coming into the OPD. So these are some of the clinical features. You have to identify the clinical feature in the children's, especially the children's cannot explain to tell you the things about going on. So take the history from the mother or the father. What are the chief complaints of their children? So the mother told us that the child has fever, cough, and child is not gaining weight. And after taking the history, mother told that the father died. Father is a chronic alcoholic patient. 2 years back, he got the TB infection, and later on, he shifted to because he is a maid servant and father is laborer, so he back to their hometown. So when I talked to him, okay, is there any report available? So the child did not have any report. So around the clinical feature by assessing the clinical feature, we did a chest X-ray in the children. So when we did a chest X-ray, we found that there is right upper zone cavitary region was found. So this right upper zone cavitary region is very highly suggestive to the tuberculosis, and other are miliary tuberculosis and hilar and mediastinal lymph node. These are some of the X-rays which is highly suggestive of the TB. So first we do the chest X-ray. When these chest X-ray we found that this is the highly suggestive towards the tuberculosis. Then we send NAT. And in NAT generally we are doing CBNAT and chip-based TrueNAT. These are the TrueNAT which is approved by our program basically. So by doing the CBNAT we found that the MTB was detected and this patient is of preference PTB. So after getting these reports, we start the regimen of drug sensitive PTB because the weight of the child is 10 kg. So as per the weight band of the children, this child comes under the category of 8 to 12 of weight band. So we start the 2C plus 2E regimen. And the child was comfortably discharged from our ward. And after 7 days, he come back to us with the complaint of the vomiting, nausea, abdominal pain. So basically, I just want to add one more thing because in the children's we have diagnostic difficulty to identify the sample also. In the adult we get the sputum sample, but in the children's we get the gastric aspirate sample, gastric lava sample, induced sputum sample because child cannot expectorate. So these gastric aspirate, gastric lavas, and induced sputum samples are some specialized samples. You have to know how to take these samples. This is very essential to get the good yield from the children. So these are these samples. If you send these samples, you can get good yield the pediatric cases rather than the sputum smear cases. And one more thing I want to add that the child, the father was died due to TB and the record are not available. So we have to also rule out the drug resistance in this case because the record is not available. These children also comes under the presumptive drug resistant TB cases as per the NDP guideline. So once we send the CBNet, we found that this child is drug sensitive, and later on, because the smear is negative, so we send the culture, and later on, for the culture is also sent for the first line LTS to find out the isometric pattern. Later on, in this case, as the child was born at home, and the vaccination schedules is not available with the mother. So it is assuming that child did not get the BCG vaccine. Basically, BCG vaccination has more protective effect in the children. basically. The BCG vaccine, at least 85 to 90%, it protect from the very severe form of the TB. And in the pulmonary TB, it protect near about 70 to 75% of the cases. So it is assuming that BCG vaccination also child did not get. BCG vaccination right now, as we know that it is in our national immunization schedule at the time of birth and can give up to the up to 1 month. And this child is also a very malnourished child. BMI is under weight category. So as this child is malnourished, so the nutritional assessment is very important in the children. Because malnourishment and the tuberculosis both are the vicious cycle. As the malnourishment causes decreased immunity, that will cause tuberculosis, and tuberculosis later on cause anorexia, decreased appetite, that cause malnourishment. So both things are correlate with each other. So we have to also see malnourishment. Especially, we have to check the weight and height of the children which are coming above the month 6 years, and under 5 years we have to do the anthropology to find out the acute or chronic malnourishment. So these are some of the important things which we found in these children. So actually malnourishment is a very important factor in these children because malnourishment also TB also a catabolic disease is added 20 to 30% of calorie intake as also additive in the TB food. But as the mother is working in a diet as a meat servant, so adequate diet is this child is not getting the adequate diet. So this is also one of the factors which may causes tuberculosis. Yes.
Okay. Can you also highlight how you introduce the ATT in this patient after developing, resolving the new LFT just comes down to the down? How you introduce the ATT in this patient?
First, first we did the liver function test, and the liver function test was above 3 to 4 times, and symptoms had also. So we stopped the ATT. First, after that we do the liver function test 3 to 7 days later on. So first day we introduce the capsin at full dose. Later on, we repeat the liver function test after 3 to 7 days. Then we add the isoniazid, and after some time, 3 to 3 days, when the liver function test was 2 times of the normal, we add the pyrazinamide. And after adding all the drugs, we wait the liver enzymes are not raised, so full regimen was tolerated by the child. So we add all this.
Thank you so much, sir. So we have added sequentially all the drugs in full doses in this patient, right? Dr. Babu, your hands were raised. You want to say something? Okay. Ma'am, as the modified regimen which we are giving, which is hepatotoxic safe, but we are also seeing that there is a rising threat for XDR TB in the country. So how to go about all this with this scenario and adding second line drugs in salvageable regimen in this patient?
I mean, I would say that the first line drugs, rifampicin, the most hepatotoxic is pyrazinamide, followed by INH, followed by rifampicin. So all the three major drugs, they have some sort of hepatotoxicity. The safest drug is ethambutol. So now we have to, as I said, if the disease is not severe, you can even wait. But in this case, whenever you have a case of severe tuberculosis, then you have to give a salvage regimen. And salvage regimen is now we are well aware, streptomycin, amikacin, they have moved on to the reserve drugs. Fluoroquinolone itself is a reserve drug. The only safe first line drug is ethambutol. So amikacin or streptomycin, fluoroquinolone, that is levoflox, and ethambutol. Now, in some cases, I mean, once you, as Dr. Lokha said, once you restart, it's, I mean, it's a personal preference. Some clinicians, they prefer to start with INH, but I prefer to start with rifampicin in the full dose. Suppose the patient, you give the first dose and the patient suddenly, again, the LFT starts to increase. So you need to identify the drug. You know, there are two kinds of hepatotoxicity. One is idiosyncratic and the other is dose related. So idiosyncratic is even with the first dose of the drug, your LFT will jump to more than 500 or even 1000. So that means that your child is hypersensitive to that particular drug and you are not to start that drug in any circumstance. So, but in majority of the cases, it is dose related. So now a lot of research has gone. Initially, you know, we used to give in graded. We used to start with a low dose, then build up the like start rifampicin half dose, then build up with the next full dose. But now the clear-cut WHO recommendations and also under the program, we are giving the full dose. Start with rifampicin or INH, but people majority we prefer rifampicin and then introduce the next drug that is INH and finally pyrazinamide. And as I said, most toxic is pyrazinamide. If you're not able to add pyrazinamide, never mind, continue with RH ethambutol. Uh, in this case, the regimen has to be continued for 9 months. So now coming to as the question which is in the chat box, you know that majority of these drugs are second line. Yes, agreed they are second line. You know, SLIs they are reserved drugs, fluoroquinolones are reserved drugs, but then we have no other option. And sometimes, you know, in rarest of rare cases where your child does not tolerate the regimen of the first line drugs, you may have to take the help of the second line drugs. And the safest second line drug as concerned with hepatotoxicity is cycloserine. You know, bedaquiline, delamanid, ethinomide, PAS, high-dose INH, and pyrazinamide, they are hepatotoxic. Coming to the safety of second line drugs which are less hepatotoxic, safest is cycloserine, followed by clofazimine, even fluoroquinolones. But in rarest of rare cases, you may even have to stop fluoroquinolones. Then your regimen will have, you know, cycloserine, clofazimine, and linezolid. But that is in very, very rare circumstances. So I think I must have answered, you know, in great detail this question, you know, which was raised, and I thought it's a very important question. You know.
Thank you so much, ma'am, for the detailed description of the regimen. Good afternoon, Dr. Chopra, sir. You want to say something? Dr. Chopra, sir?
In fact, you know, we have a lot of pediatrician colleagues. I can see Dr. Sushant Mane. I can see Professor Kamal Singhal from Lady Harding Medical College. I mean, your inputs, if you want to give any.
Dr. Chopra, sir, you raised your hand. Unmute.
There is a echo with
Sir,
your
you are
voice.
audible, but there is a lot of
There is a lot of echo. Yes, Dr. Kamal.
I think there's some technical error issue sir is facing. So meanwhile, we'll move to Dr. Kamal Singh. He's a professor. Kamal Singhal. He's a professor at Lady Harding Medical College in Kalavati Saran Hospital. Sir has a great experience in TB diagnostics, TB and diagnostics. So he will be sharing his videos on importance of gastric aspirate and induce sputum samples. How to take. Dr. Kamal Singhal, sir.
Dr. Kamal, are you there? Is there? Okay. So, you know, Dr. Kamal Singhal has been really forthcoming.
Right, you have to unmute yourself.
We can't hear you.
Please unmute
yourself.
No, yes.
Yes.
So
hello, Kamal.
I could not. Hello, madam. Hello, everybody. I could not unmute. The host had those superpowers. So now that I have been able to unmute, So yes, ma'am, as you have been discussing, these three drugs are the mainstay when it comes to managing drug-induced liver injuries. And the least hepatotoxins, of course, depending on that, we use these streptomycin, levofloxacin, ethambutol. And the now, the part that I wanted to comment on is that the real problem that we face is in terms of the sample that is being collected. The problem here is that the child has a possible bacillary disease, and on top of that, the sample that we get, if it is not representative, it doesn't lead us anywhere. So the problem starts there itself, that in most of the patients, we do not have a microbiological diagnosis because the sample that was collected was not representative. The inherent problem is that child will not expectorate, but the other surrogate techniques available to us, if they have not been followed up well, we will not be able to get appropriate sample. As of now, I would want to share a bit of, if you allow, ma'am, should I show?
Yes, sure. I mean, that's a big asset, which you have created for all the pediatrician colleagues. And he has been, very kind enough. He prepared this video, and we have this on our NTP website also, in which what's the ideal way of induction of sputum as well as gastric aspirate. Over to you, Kamal.
So this is a small video lasting for around 3 minutes. I hope the audio in this video is audible. If there are any questions, we will take up in between. Let us just go through this video and then let us see. This is about how to collect and induce sputum in a pediatric patient.
For taking induced sputum, keep the patient fasting for 2 to 3 hours.
Just to check, is the
yes, we can hear you. Beautiful sound.
For taking induced sputum, keep the patient fasting for 2 to 3 hours. Take consent and explain the procedure. This procedure should be done in a well-ventilated room with an exhaust fan, with all the personnel wearing the face mask. Baseline values of respiratory rate, pulse rate, chest retractions, any wheeze, oxygen saturation should be taken prior to nebulization. Now, in the first step, administer salbutamol. It can be given either by nebulization using a jet nebulizer in a dose of 0.2 mg per kg in 5 ml normal saline, or it can also be given by an MDI with a spacer and a face mask. Give 2 puffs of 100 microgram of salbutamol MDI. After this, nebulize with hypertonic saline, which is a sterile, commercially available preparation. 5 ml of 3% saline is given via a jet nebulizer attached to an oxygen at a flow rate of around 5 liters per minute. If suppose there is no sputum, do chest wall percussions. The purpose of doing chest percussions is to bring the secretions from the peripheral to the central areas, and from where the child can cough out the secretions. For percussion, we have to cover all areas of chest in sitting, supine, and prone position. Now, if after doing chest percussion, the patient can produce sputum, the sputum can be collected in a container. If the child is still not able to expectorate, then sputum can be collected by suction through a nasopharyngeal tube using sterile mucus extractor. The catheter is inserted through the nose. The length to be inserted is measured from the side of the nose to the angle of the mandible. After applying lubricant jelly, the catheter is gently inserted into the nose. The other end of the extractor is connected to gentle suction of not more than 100 centimeters of water. As the child coughs, and in a smaller child, as the child cries, the secretions that are coughed up are collected before the child swallows them. After the procedure has been completed, monitor the patients for any side effect for a duration of at least 30 minutes after the procedure. You can monitor for respiratory rate, pulse rate, chest retraction, and wheeze.
So I hope the audio was clear. And
Yes, sir. It was very clear, and in fact, there are few questions in the chat box regarding the induced sputum. So, one query is how much fasting do we require? 3 hours or 8 hours of fasting before we call the patient for induction?
okay, ma'am. So when you are going in for a big surgery, they would want the child to be NPO for 6 hours, 8 hours. But here, what we are dealing with is another procedure. So if somebody has had only clear fluids, maybe even 3 hours for us is enough. If somebody has had a proper meal, then anything beyond 4 hours for this particular procedure is enough. So it is not the same as what a surgeon would take before a major surgery under GA. So anybody who has been an NPO for more than 4 hours will be enough, and somebody who has taken clear fluids around 2-3 hours is fine.
Sir, during screening, when the patient is asymptomatic, respiratory asymptomatic, then also it will help us in reaching to some diagnosis, the induced sputum during screening.
I didn't get. We are doing a procedure only when there is a pre-test probability that the child has TB. That's where we begin. If
Yeah.
the pre-test probability of a likely diagnosis is not there, so howsoever sensitive or specific your test may be, it is not going to yield any results.
So basically, we
before you
cannot use
proceed,
it. No, we cannot use it for a screening purpose. It is the patient has to be symptomatic
yes,
or presumptive for tuberculosis.
it
Then
has
only
to be.
No, even there has to be a chest lesion. I mean, I'll discuss that algorithm in detail. I mean, presumptive TB, the first thing which needs to be done is a chest X-ray. If the chest X-ray shows lesions, then only you subject the child to, gastric aspirate or induced sputum or sputum based on the age and hospital setting.
So as madam said, the more you have in terms of other than clinical, if you have radiology, the more are the chances that you'll get something positive. And it is for us to decide that what cutoff will take. So as of now, if you look at the algorithm that we have, we begin with chest X-ray, and it tells us whether it is a highly suggestive of TB, not suggestive of TB, or we are not sure. In that scenario, we will test accordingly. So it's a very, very costly investigation. So has to be done in that particular order. So
thank you.
if there are any questions related to this, fine. Otherwise, I have a 1-minute video of how to take a gastric aspirate.
Sure, sir. Then go ahead with the video first. And these are the only questions with the induced sputum.
So we will now proceed with the video on gastric aspirate. It's a very short one, a 1-minute video. You'll have to be really alert to to be able to.
For taking a gastric lavage, keep the patient fasting overnight, explain the procedure and take consent. You can either use a Rice tube or an infant feeding tube. The length to be inserted is measured from the tip of the nose to the tragus and from tragus to the xiphisternum. Apply a lubricant jelly to the tube. Gently insert the tube perpendicular to the face and fix it. Confirm the position of the tube by pushing 5 ml air into the tube and hearing for the gush of air with a step at the epigastrium. Now gently aspirate in supine position. If there is no aspirate, try in the left lateral and right lateral position. If still there is no aspirate, slowly administer 10 ml normal saline and again aspirate in supine and if needed in left lateral and right lateral position. If still needed, you can give additional 10 ml bolus and again try. After the aspirate has been collected, gently remove the tube by closing the cap or pinching the tube.
So
thank you. Yeah. I think it was good, knowledgeable, sir, and thank you so much for sharing this. Dr. Kamal, can we take your can I have your opinions? Kamal Chopra, sir. Dr. Chopra, sir.
Good afternoon. Am I audible?
Yes, sir. Now you're audible.
Yeah. This is a very good initiative regarding pediatric tuberculosis. In the field, most of the doctors they feel difficulty in diagnosing and even management of pediatric tuberculosis. And two videos which have been shown by Dr. Kamal from Lady Harding, they are very useful for taking these samples. Regarding this case, if the doctor have done the screening of the contacts, so that child patient could have been detected very early or suspected very early. And if TPT would have been given, we could have saved the patient from getting this disease. Second point was regarding BCG vaccination. This could be checked by the even noting down the scar also. So these are the two comments from my side.
There was no scar present in the patient.
Okay, so no students.
I think that's a very important point, that is screening of the context. Because over here, the father died 2 years back, and even the sister is suffering from tuberculosis. So that means this could have been prevented had the screening been done and the child put on prophylaxis.
Dr. Sushant, you've raised your hand. You have a question?
No, I don't have a question.
Welcome, Sushant. It's so nice to see you. Sushant Mene needs no introduction. He is Associate Professor and Nodal Officer Tuberculosis at JJ Hospital, Mumbai. Sushant, over to you for your comments.
Yes, ma'am. Good afternoon. I just wanted to add one thing. When the screening question came, and the induced sputum or this GL was discussed, like Madam rightly pointed out, first step is X-ray chest when we're talking about presumptive TB. When we talk about screening, okay, sputum does not come as the first step in screening. It is always the X-ray and then the collection comes. So, what we have seen is for screening, sometimes even the symptoms are not taken properly. There are no chest symptoms, or even the lung X-ray is not done, and directly an induced sputum is seen and it comes negative. So screening has to start with symptom screening first. Then we plan depending upon the X-ray what it is. And as far as there was one question on PUO. So again, when we talk about pyrexia of unknown origin, we must know what we are looking at. If nothing is present in the lung clinically as well as on X-ray, it is highly unlikely that we are going to get something on sputum, that is CBNAT. And as Kamal said, it is a very costly investigation. We should not keep on repeating the investigation. Localize the lesion and then go ahead with CBNAT. Thank you.
Thanks, Sushant, for, very important pertinent point. And regarding to prophylaxis, although that is not what we are discussing right now, the emphasis is on diagnosis and drug-induced hepatitis. But, prophylaxis, we have 6 months of INH, and also now the program is going towards 3 HP. That is weekly regimen, 3 months weekly regimen, total 12 doses of rifapentine and INH. So that's what the advantage, and the compliance is supposed to be, better than the 6H.
Thank you, ma'am. With this insight, I would like to call our national expert, that is no other than Dr. Sangeeta Sharma, to give her expert opinion in regard to this particular case of PTB with drug-induced liver injury.
So, I'll be just taking you the house through to the algorithm which we are following for pediatric pulmonary tuberculosis. This does not include extrapulmonary tuberculosis. And we are lucky that in this session we have, more than 280 who have joined. And there are my colleagues from AIMS, Rishikesh, Bhubaneswar, Bhopal, and one more AIMS at Hawaii. So, Bilaspur. So I welcome you all, and also the state TB, the DTOs, etc., the CTOs, all my pediatrician colleagues who are here with us. So just running you through the current algorithm of pediatric tuberculosis, pulmonary tuberculosis. So as we have seen, whenever there is a case who presents with persistent fever, each and every word about this is important. The child should have persistent fever and it should be documented. 2 weeks is the duration, but it can be even less than 2 weeks, but ideally, because these guidelines are formulated to keep majority in mind. So you do not feel that if the fever is less, say a week, with pleural effusion, it cannot be tuberculosis, it can still be TB. But what we are talking in the guidelines is of majority of the children who we are catering this algorithm to. So persistent fever documented more than 100 degree Fahrenheit without a known cause. and the cough should be unremitting. There are different kinds of coughs. Pediatricians, they are well aware. There could be intermittent cough in cases of, bronchial asthma. Then it could be a delayed recovery cough. That means initially the child had a viral episode, but it takes some time for recovery. But that is not the kind of cough we are looking at. This is like a unremitting cough. Uh, and there is a weight loss. Now, the weight loss is also now being defined, that is weight loss of more than 5% over the last 3 months. And this weight loss is despite adequate nutritional rehabilitation. Now, with or without a history of contact with the active case of pulmonary tuberculosis in the last 2 years. So the first thing which we do is a chest X-ray. So this is how we, have graded the chest X-rays into some highly suggestive or suggestive chest X-rays. Highly suggestive is, the first X-ray is a hilar lymphadenopathy. Then you have this paratracheal lymphadenopathy, miliary pattern, hydrocavitary disease. I think we lost the contact. Did you hear me?
Yes, it's audible, ma'am.
Okay. Because over here it's showing that the audio is gone. So whenever this is a highly suggestive chest X-ray, then the next thing which we do is, we, depending upon the age of the child, we either send the expectorated sputum, the gastric aspirate induced sputum, to approved NAT lab. So the lab needs to be certified for carrying out the NAT for MTB. So, depending upon the sample, the first thing the lab does is that they do either a NAT or a smear microscopy. So, if the NAT or smear is positive, so the first thing which can be done, that means the smear positive means I'll be discussing, that means the bacilli are more than 10 raised to the power 5. So, easily you can go ahead with the LPA. If NAT is not available, if the NAT is available, the first test to be done is NAT, which has got a limit of detection of 130 colony forming units. So depending upon the results, if these tests they are negative, then automatically the lab takes this sample up for the liquid culture, because pediatric samples, they are precious. So two specimens, they have to be collected in conical tubes and transported in the cool chain, and one specimen is utilized to perform NAT, and the second specimen for the liquid culture DST. We need to remember, because the sensitivity of the tests in children, they are poor. The direct smear has just a positivity rate of 10%, culture 30 to 40%, and NAT to the best is 58 to 65% of the culture positives. We need to interpret this. This is of the culture positive, that means almost half. So the culture positivity itself is 30 to 40%. So, but that does not mean that we should not go ahead with getting the test done. So we all know the smear, it becomes positive, 10,000 bacilli or more. And the advantages are that it is easily available, but the disadvantages are that it will not tell you about the rifampicin sensitivity. It will not even tell you about whether the organism is dead or live, and it will not distinguish between MOT and MTB. So, I mean, this is, as we discuss the cases further, these things will become more clear to you. Now, coming to the NAT, we have two kinds of NAT which are available, the CB NAT or the gene expert, and the true NAT, that is the indigenous, that is true NAT. The limit of detection, as I said, is 133 colony forming units, and they can be done on any kind of specimen, that is smear positive or negative, culture positive or negative, pulmonary or extrapulmonary TB specimens. The advantage of NAT is that it also tells us about the rifampicin resistance, and the results, they are available within 2 hours. So the report is, but the NAT, the CB NAT cannot be used as a point of care test. While TrueNat, because it's a battery operated machine, we are looking further towards this being a point of care test. So now coming on to the line probe assays. Now line probe assay the limit of detection is again equivalent to smear. So you can directly, if the smear is coming positive, you can directly go ahead with this first and the second line LPA. First line LPA will tell you about the rifampicin and INH resistance also, and the second line LPA will tell you about FQ as well as SLI. So the LPA can only be performed if the specimen is smear positive or culture positive. It cannot be performed on smear negative specimens. The other thing which I missed is you must have been hearing about expert ultra. Now ultra is one test which is we have still to adopt it. The limit of detection over here of expert ultra is 16 colony forming units. So it's a more sensitive test, but you need to understand when you increase the sensitivity, the specificity goes down. So that is the reason the program has still not taken a call on inclusion of ultra as a test. Then there is another expert which is coming up, that is expert XDR. I'm just telling you because you must have heard about these tests just to make the things a bit more clear. Now, expert XDR tells you about INH resistance, FQ resistance, and also SLI resistance. Now, liquid culture based on the DST, if you go ahead with the phenotypic DST, that means you can get DST to all the drugs. The genotypic DST means that after the culture, you subject the specimen to the first and the second line LPA. So coming on, this is in nutshell all the microbiological tests which are available till date in our program. And as the national strategy, what we are doing is that we are offering a rapid DST to rifampicin to all notified TB patients before initiation of treatment. And once the initiation has been taken place, then within 15 days, you also need to know about the FQ resistance, especially for RR TB patients. So once you have sent the specimen for the NAT. Now the result can come NAT positive. As I said, it could detect rifampicin resistance. So you go the rifampicin resistance DRTB pathway. I won't be going into detail. If it is RIF sensitive, then you start the treatment with the first line drugs, as happened in our case. So now, if the NAT is negative, then please do examine the child as a whole. Look for other sites. We have had cases like cervical lymph node enlargement. So palpate the neck. There could be a cervical lymph node. Then also, just undress the child. There could be, involvement of other like bone joint TB or where the bone. We had a case recently diagnosed. The mother did not tell, but then there was a lesion on the bone. We did a FNAC and it turned out to be XDR. So always examine the child in a whole, and if need be, you may have to send the specimens or refer the child to a higher center. But if the chest X-ray is highly suggestive and you are not able to fish out the organism, you are still safe to start ATT as a clinically diagnosed case of pulmonary tuberculosis. So these are the highly suggested chest X-rays. On the right-hand side, you can see the non-specific radiology. That means collapse consolidation or infiltrations. In this case, again, this is how the algorithm will flow, as I'll tell you. But mind you, the early lesions they may be missed on a chest X-ray, and disease activity is not indicated by shadows. Remember this. Superimposition of old and new shadows and treatment decisions based on imaging alone can be risky. But mind you, still, chest X-ray is the first and only suggested chest X-ray is a good screening tool. So, like in this case, if you have a chest X-ray with a non-specific radiology, as I've said, you need to give a course of antibiotics. Now, the safest antibiotics is amoxicillin or co-amoxiclav. Please do not prescribe fluoroquinolones or linezolid because they have a ATT activity. And if they're still persistent, then obviously you need to send the specimens again. And if the chest X-ray is normal, then you need to evaluate the child for extrapulmonary tuberculosis. So, in nutshell, the initial step, that is a chest X-ray followed by a NAT from a expectorated sputum. If it is not available, then you need to take the help of alternative specimens and send for NAT, either 3 NAT or 2 NAT. And if the imaging is not available, then you can also go ahead with at least a sputum smear, which will tell you if these the CBNAT, etc., and the imaging, they are not available. And if you have to send the specimen for CBNAT, only a single specimen is enough. While for smear, you need to send 2 specimens. And the yield has really improved, the tests have really improved with the launch of these NATs and liquid cultures. So, but mind you, remember this line that although we all understand that disease is possibly in children, sample collection is difficult. But children of all ages, they do have bacilli in their specimen, and attempt should always be made to demonstrate MTB and confirm DST. So that is the, in nutshell, how we do the diagnosis. Then depending upon your test, then you have to do a correct categorization. I won't be going into detail because the next sessions will be going ahead with this. And now coming to the first line drugs, you need to be aware that all the first line drugs, they are available in the form of FDC. That means we have 3 drug FDC, R, H and Z. Ethambutol is kept separate and the doses are as per the weight band. The drug dosages, they are different from adults. This is for the adult colleagues who have joined us. For adults, you have rifampicin of 10, but in children we give 15. INH we give 10 instead of 5. But when the child's weight crosses 40 kg, it is the adult dose which is milligram per kilogram which is taken into account. So, over here, I would like to also say that initially when we were giving the dots, the pyridoxine was a part of the that strip which were given at home. Jo khata tha patient, that was pyridoxine. But now we remember to also give pyridoxine to be there. So, with this, it's a big thank you to all who have joined us. We are in India TV program. We are caring for 1.5 million cases. And we have a target, which we have still not achieved. That is 3.5 million was to be achieved in 2020. So thank you all, who have joined us patiently, and we wait for your feedbacks.
Thank you so much, ma'am, for this such an elaborative talk, which has explained everything from how to approach a patient who is symptomatic, and from X-ray to newer diagnostic modalities and to culture, and how to treat the patient with the currently available FTCs. Thank you so much. We have completed the case discussion, the opening of the national experts. So we are sending a link for the post test link in your chat box. Kindly attempt that. The email has been sent to your registered email ID. Now I request Chairperson National Task Force, Dr. Ashok Bhardwaj, sir, to give his closing remarks for the session. Sir, please.
Thank you, madam. So, as DDG started the inaugural session, he told very difficult to diagnose TB in children. Firstly, because the symptom of TB among children, they are similar to other childhood illnesses. And second, which Dr. Sangeeta just told, because the difficulty in assessing pulmonary sample, as children often swallow sputum, and the lower sensitivity of microbiological test in children further add to this difficulty. So it is very difficult to diagnose, but I am thankful to Dr. Singhal. Dr. Singhal was showing those 2 videos, and we should use those videos when we are undertaking TB training in medical colleges, particularly among pediatricians. So I will request all the medical colleges so that they can access, if Dr. Singhal permitted, they can access this video and they can show these video during the training. So Sangeeta, my major concern is because we know that we have 12% proportion of pediatric TB cases, but when we review the medical colleges during JTF meeting, you have attended one, so it is around 6%, and see in some medical colleges, it varies from 0 to 3%. So we have to have the pediatric cases notified from the medical colleges so that we can get exact figure in our country. So
Yes, sir.
either the figure which you will be coming to Udaipur for the review of North Zone, you will be seeing that there are colleges in the zone which have 1% pediatric TB cases, 2% pediatric. Some medicals have reported 0 cases. So looking at that, it seems that pediatric TB has been eliminated from the country. But it's not so, because the cases are diagnosed by the pediatrician, but these cases are not notified to the system. Unless they are notified, they will not come in the load in the country, and we will not be showing that this much is the load. And still, yes, of course, these procedures, they are very difficult to adopt in the community. But of course, at least all medical colleges in the country should do these procedures so that we are able to have the sample. And my last message is we have to have the exact microbiologically confirmed diagnosis for pediatric TB also. But when we see that only 20% we have got this, and 80% it is clinical diagnosis. So we have to proceed for the program is going for University DST, so we have to adopt that. So thank you very much. Thank you, Sangeeta, for giving me a chance to be with you. Thank you.
Sir, it's a pleasure to have you with us. And I mean, your words of wisdom, they really mean a lot. I mean, that is actually true. When we are looking at the global TB burden, out of 10.6 million cases, 1.3 million in children. And out of that, WHO estimates that 31% of caseload is in children of 1.3. So we are really missing our cases. That is the reason, sir, this initiative has been taken with the help of all my other pediatrician TB experts, from other medical colleges like Dr. Barinder, Dr. Kabra, Dr. Meenu Singh, Director AIMS Rishikesh, then Dr. Ira Shad, we have Dr. Sushant Mene, then we have Dr. Amber, Dr. Krishna Gula, and other colleagues. Nonetheless, each and one is so important to us, and their feedback is very important. So this is, I would again say that this is a monthly activity. This time NITRD has done it. Next time we have already a roster which is planned. So it will be held on every third Tuesday, 2 to 3 p.m. And the next host we will is AIMS Rishikesh. So the next activity will be hosted by AIMS Rishikesh on the third Tuesday of June, that is 18th of June, 2 to 3 p.m. So I request each one of you to join us, and that is how we will be going. As I said, this case was a very for majority of you, you must have felt that this is a very, very simple case. Why did we get it over here? But the motive was actually this. It was decided that we would be starting from a very simple case and then building up the blocks as we move further. So thanks each one who has joined us. And I, on behalf of my colleagues, Dr. Alok Yadav, Dr. Sunol Meena, and my dear student Biswadeep, I thank you all for joining us. And greetings from team NITRD. Thanks one and all. Thank you.
Thank you, ma'am. For those who are asking for the video of gastric lavas and induced sputum, sir has already shared the link in the chat box, and it is available on YouTube also. Dr. Kamal Singhal, you want to say something, sir? Your hand was raised.
That is the only thing. Many people were asking for the link. It's there in the chat box. You can take it from there.
Yeah, that is there in the chat.
Otherwise, you search my name, you will get it.
Yeah, great, sir. Thank you so much for sharing it.
Kamal has done a good service to pediatricians, and this he did long back.
So with this, we end today's session with the message that yes, pediatric TB is difficult to treat, and getting a right sample is again a difficult task. So we have to look for these techniques like gastric lavage, which has a good yield if taken in a correct way. And Dr. Kamal has done a great job by sharing the technique of how to take it. And feedback. One more thing I would like to ask for your feedback, which has been shared in the chat box, because that feedback will help us to do better and improve ourselves so that we can make these clinics more useful and help take them to a next level so that knowledge dissemination can be happen to even to the peripheral districts also, and we'll mutually we can help each other through these clinics. Like ma'am has already announced that next session we are hoping is on to 18th of June 2024. That is third Tuesday of every month we'll be doing. It will be presented by Dr. Meenu Singh and her team from AIMS Rishikesh. Thank you so much. With this, we end today's session. Thank you everyone for joining and making this first session so successful and launch of the Pediatric TB Eco Clinic a success. Thank you everyone. Have a great day.